Hello everyone, this is Kitty Clinical, and today we're going to be doing a brief overview of chest pain. This is a very high yield topic, especially on your boards, USMLE, in your practice. It's something that you're going to have to know like the back of your hand, and every chest pain is different. Some people have chest pain that is pretty straightforward. Other people have atypical chest pain that has a little bit more nuance to it, and you might have to think about what the diagnosis is. But yeah, I mean, chest pain falls into a lot of categories, and that's why we call it chest pain. We don't say this is an MI. You have to work to see if it is an MI. You have to check the troponin, you have to get the EKG. If you're worried about chest pain, there's three things that I'm really worried about, and those three things are myocardial infarction, pulmonary embolism, and aortic dissection. Those are the three things that I would say I'm most scared about when somebody says that they have chest pain. Yes, there's a lot of other causes of chest pain. You can make the argument that pneumonia causes chest pain, costochondritis, but those are the three ones that I'd be the most scared of: MI, PE, and aortic dissection. So for the most part, it is true that most of the diagnosis can be made through history alone. I would say maybe about 70 to 80% of your diagnostic tools can be found in the history of the patient. What was the pain like? What did it feel like? Was it sharp? Was it dull? How bad was the pain on a scale of 1 to 10? Where is the pain located? Did it start in the morning when you were waking up? Right before you went to bed? Were you sitting in the toilet? Not sitting in the toilet, sitting on the toilet. And what do you have a family history of heart attacks or heart disease, right? Look at the social history. Do they smoke tobacco? Did they use cocaine before they had the chest pain? These are all things that you should definitely be mindful of. And the patients are not going to be so easy to tell you that they snorted cocaine before they came to the hospital, obviously. This is why you check a UDS and you get all these other things, and you find out more from the patient to get more information about these things, right? So we talked about the three scariest causes of chest pain. We talked about the history, what to look out for, also surgical history. Did they have any recent chest surgeries? Because that's also obviously relevant. I mean, if they had just had open heart surgery, I mean, that would be something that would be very obvious from the history. But you'd be surprised. I've gone into see patients and they didn't say that. They never told me that. They just assumed that you knew about it because it was already in the patient chart, when in fact they've never been to this hospital before and they just assume that everyone has their information freely. It's very, very surprising. You'd be surprised how little is out there about patients' information, and you have to go digging for it. And everybody has a different EMR, and they did all their care from another facility, and then you have to get a release of records, right? So there's all these things that take a long time to figure out, and you really have to get a good history to get all the information. So social history, family history, sexual history, probably not that relevant, but surgical history, allergies, do they have any allergies to anything? That's something. Do they take any medications, any changes in medications? Because who knows, maybe they started taking the medication and that started causing chest pain. Okay. All right, so differential diagnoses. So we think about chest pain. We already talked about the three scariest causes of chest pain. We've also talked about heart, lungs, but there's also other organ systems in the chest, obviously, right? We talked about costochondritis, rib fractures, a big one to think about. This is another reason why we get a chest X-ray. But the other thing the two other ones to worry about, I mean, besides, I guess, anxiety could be chest pain, like panic attacks, but also GI, right? Because you also have to think about the esophagus, GERD, acid reflux can cause a little bit of, heartburn is what we call it, right? And the other thing is, don't forget to look at the chest too when you're examining the patient, because there were times that I've heard stories of patients reporting 10 out of 10 pain left side radiating to the arm, and nobody ever bothered to look at the chest. And if you had looked at the chest, you would see that there was shingles along the dermatome that went to the left chest, the left arm. So always think about these things when you're doing a chest pain workup. Now, as far as what to order, so this is going to be useful for you to know what to order for Step 3 CCS, but also for your admissions. Obviously, you want to order an EKG and troponin. Those are the obvious things. Chest x-ray, also another thing that you should definitely order for chest pain. We'd already talked about the different etiologies and looking at the lungs, making sure the ribs are intact. Getting your other labs such as CBC, CMP. Also, don't forget to check a magnesium too, because as you may know, low magnesium can be associated with torsades. So that could also be, chest pain. And then the D-dimer, be careful with the D-dimer. You always want to look at the Wells criteria for, for D-dimers. And, we can have a separate video on that. But I just briefly want to talk about the D-dimer in this video because it is a tricky subject. If you suspect a PE, then order a D-dimer. But just be mindful that if you randomly sample the hospital population, yes, even not just the patients, even the even the healthcare workers, they're probably under a lot of stress too. D-dimer is a stress reactant, right? It's going to be high when you're under a lot of stress. It's not that specific to. It's not a very specific test at all for DVTs or PEs. But when you order it and it's high, you've dug yourself the grave of having to go through the CT angio. You have to order the CT angio because that was the protocol. You thought about PE and you ordered the D-dimer. It was elevated. It was like in the thousands, right? Well, now you got to order the CT angio, and you're putting this patient through IV contrast, and you look up their labs, and you find out that their creatinine is 2 or 3, their GFR is shot. So you gotta watch out for these things, right? I would order the D-dimer. You would obviously follow, MD, Calc, Wells criteria, whatever. But you should also be mindful of, just in general, ordering tests and knowing what to do with them. Okay, so we'll just leave it at that for now. And chest pain, like I said, broad topic, very broad differential. And hope you enjoyed this video. If you have any questions, don't be afraid to ask them in the comments down below. And of course, like and subscribe to my channel. Feel free to share if you enjoy my content, and I will see you in the next video. Take care.